We can take a question. So our next speaker is Dr. ROSHMI Gupta. ROSHMI will be speaking on inflammation, infections, or in the orbit, hits and misses. So ROSHMI has trained at Calcutta Medical College and went on to obviously do a fellowship at LV Prasad Eye Institute and John Moran Eye Center at Utah. And she set up the first and sort of the largest oculoplasty services in Karnataka and heads the oculoplasty and oncology services at Narayan Netralaya. She has received the best video and best orbit paper and the Raman Mittal paper. And she is also published a lot. But more than that, she's a dear friend and excellent presenter, and her ability to algorithmically think through any difficult sort of orbital or any situation is, I think, something that's just her forte, and she can break it down and really simplify it and come down to a diagnosis. So thanks, ROSHMI. Pallavi, we'll just take your question. We have time for questions. So
thanks, Avri. That's a very generous introduction. Okay, we are going to be talking about hits and misses in the orbit, tumor, inflammation, infection. So it's a pleasure to be part of this instruction course. And we will directly go into the cases. The first thing I saw about this patient was this. This is last year, May. The radiological report, which says suspicious for fungal infection. And then this is the photo that came my way from another practitioner in the same city. Yes, that is a little scary, definitely. It's been there for about 3 or 4 days. The patient is a diabetic. However, if you start looking at these images, the orbit looks inflamed, the nasal mucosa is thickened, but look at the sinuses. They're absolutely clear. All sinuses, I haven't put all the cuts, and so initially it was seen by one of my ENT colleagues who took 2 biopsies from nasal turbinate, which were negative for tumor, for mucor. Once again, if you look at this, you'll see the recti are thickened, okay? And they're taking up contrast. And you'll look at the shape of the recti. What does it remind us of? Now, retrospectively, if you go back to this picture, take a look at this part of the lid. There's a clear-cut lateral flare. So in that situation, it was a little difficult to persuade people to put the patient on steroids. But that's what we did. And this is after the first cycle of IVMP, he resolved. He was also diabetic, so ultimately we had to go into periocular steroids, and we had to get another nasal biopsy before the rheumatologist would agree to put him on immunosuppressants. But yes, it's a year down and he's fine. So keep at it. We need to correlate clinical and radiological findings. Case 2. This is referred to me as an orbital cellulitis, duration of less than a week. It's red, it's swollen, but the patient is not in any pain. And orbital cellulitis, one of the first things I do, a suspected one, is to do a blood count. WBC is 1900. That should raise 1900, not 19,000. So that should raise all kinds of red flags. The imaging that he went out and got was not great, but you can make out that there's something in the preseptal area, a soft tissue mass. And when we did the biopsy, you can see a mass, this is the orbicularis, a mass suborbicular, which is a kind of a layer. So we took that out, and it turned out to be atypical lymphoid cells with CD3 positive, high-grade T-cell lymphoma. So we need to correlate ocular and systemic findings. Case 3. Okay, this is, you realize that I'm very old. I started practicing before bleomycin was on the scene. So this is one of the patients, when bleomycin came on the scene, I was very excited. You see the fluid level. Oh yes, these are macrocystic lesions. We can aspirate, we can put a sclerosant. Oh yay. And this is WhatsApp follow-up. Our patients are like that nowadays. So the patient has recovered perfectly. But then what happens? This is not a hit, not a miss. This is, just what it is. Then what happens? I see another child, similar onset. They could do only an MRI, only a CT scan, not an MRI. But if you can make out in the MRI also, the internal density is low. And if you see that point, that's a phlebolith. That's a pretty clear indicator of a venolymphatic malformation. Because cavernous hemangioma doesn't develop phleboliths. It's the venous malformations that develop phleboliths. So here again, I went in all confident, okay, I'm just going to aspirate and put a sclerosant. What I missed out, what I forgot, was when the child presented, he was anemic. And so to correct the anemia, it took a month. So by the time I went in there, it's all solid. It's clotted and organized. So ultimately, I had to, go in through a lid crease incision and evacuate the lesion and then put sclerosant. So let's remember that a lot of our lesions show a temporal shift in the nature of the disease. If you've seen a patient once and you're seeing them again after a month, please reevaluate. This is a lady who came with a pretty typical dacryoadenitis, and she had the pigmentation on her feet, which she developed. We took a biopsy, which showed granulomatous inflammation, non-necrosing granulomatous. Okay? So once again, this particular patient is a medic. So a lot of people pitched in with their opinions that yes, it can be sarcoid. No, sarcoid is not so good. It's probably TB. We need to take care. We went through PCR. We went through quantiferon. Nothing is indicative. So ultimately, the patient refused to have systemic steroids, and we treated her with periocular steroids only. The lacrimal situation resolved. However, a little later, she developed hilar lymphadenopathy and collapse and fibrosis of the inferior lobe. Okay. Second opinions are good. Maybe third opinions are good. Half a dozen opinions are not good. So probably what we could have done is probably started her on ATD and then given the steroids. That could have been a choice. And this lady has been suffering this kind of a thing from 2013 onwards. Initially, she was diagnosed as a sarcoidosis and responded to steroid. And every time the swelling comes up, she puts herself on a dose of steroids and maintains herself on 5 milligram of steroid. All right? But now even that's not enough. She's in pain. And if you look at it, the entire upper area is lumpy. And what's a problem is that it looks like that the rectus is swollen. She has never been biopsied. She turned out to be IgG4 related disease, and this is with the steroid. And then the next step now in a particularly stubborn IgG4 related disease would be rituximab, because rituximab deals with the B cell related conditions. And ultimately, IgG4 related disease, you look at the cells, they're plasmacytoid cells. So they're coming from the same family of cells. So that's how it works for this patient. So I realized that in 2013, whoever's seen that was not that aware of IgG4 disease. So possibly we need to keep reevaluating old patients in the light of newer knowledge. Do we have time? Okay. Quickly. This again, this is long back, 2014. This patient definitely has a vascular lesion, and this is all diffuse, all over the muscles, all over the optic nerve. Obviously, we can't take the whole thing out. So I injected some cyanacrylate glue and debulked part of it. In 2016, she comes back saying, look at this, it's coming back. And so that is when I started her on the bleomycin injections. 2020, it comes back for a recurrence, and you can see it's mostly the anterior lesion, a little bit at the back. So bleomycin injection, and this is how she's maintaining now. So you might need to treat a patient multiple times, but we need to replan in view of newer advances. Thank you.
Thank you, Roshmi. That was excellent cases with a lot of twists and some humor also, and how we have to keep renovating.